Welcome to the deep dive. Today we're cutting through the noise on a topic that is, I mean, it's incredibly technical, but also just so deeply personal.
It really is.
We're talking about in vitro fertilization, or IVF.
And it is such a delicate balance. For far too long, patients were kind of shoehorned into these standardized plans.
It was so inefficient.
Inefficient and often just emotionally exhausting.
And that inefficiency is exactly what we're here to talk about. Our mission for this deep dive is to really understand this huge shift in fertility treatment.
Moving past that one-size-fits-all idea.
Exactly. Moving towards truly personalized IVF protocols. And the goal here is, I think, profound. It's maximizing your real potential in every single cycle.
And when we say IVF protocol, it's important to know what that actually is. I mean, it's the entire blueprint for your cycle.
Everything.
Everything.
Yep.
Which medications, the exact doses, the timing, all the monitoring, and then the final strategy for the embryo transfer or freezing.
So the old way, that rigidity, was all about relying on these classic templates, like a long agonist or a short antagonist protocol.
Right. And personalization takes those templates and just customizes every single variable.
Based on your specific biology.
Your unique, data-driven biological profile.
Yeah.
Exactly.
Okay, so let's jump right in. Why did that traditional standardized approach fail so often? It almost seems, counterintuitive to treat everyone the same.
It was, and the consequences were pretty significant. The main failure was giving the same amount of stimulation medication gonadotropins or the same trigger shot to a huge range of patients.
With no regard for their baseline.
None. Irrespective of their ovarian reserve, their age, or how they might have responded in the past.
Yeah.
So without that individual tailoring, the outcome was just unpredictable.
The sources we looked at point to two really distinct but equally frustrating failure scenarios from this.
Yeah, scenario one is when the protocol is too strong, way too strong.
An overreaction.
A big overreaction. This happens a lot with a high reserve patient, and it immediately puts them at high risk for ovarian hyperstimulation syndrome, OHSS.
Which is really serious.
Very serious. And while they might get a lot of follicles, the eggs themselves can be sort of rushed and potentially lower in quality because the whole system was just so stressed.
And on the flip side, you have the patient who underreacts.
Precisely. Their reserve might be perfectly fine, but the standard dose is just too weak. It doesn't recruit the follicles that are actually available.
So you're leaving potential on the table.
A lot of potential. That patient might only get 2 or 3 mature eggs when their ASC, their antral follicle count, suggested that 7 or 8 were totally possible. They've essentially lost follicles that could have become viable embryos.
When you look at those two extremes, it's so clear why a standard cycle could feel like just an experiment.
Absolutely. It's pure chance. This cycle becomes more of a diagnostic tool instead of a controlled therapeutic process.
And personalization is the key.
It's the key to reducing those risks, like OHSS or cycle cancellation. And most importantly, it ensures you get the maximum real potential from that specific cycle. It saves so much time, money, and emotional energy.
That makes complete sense. So if we're moving past guesswork, personalization has to be driven by hard data. What are the essential inputs, the data points that create this equation for a custom protocol?
It really boils down to 5 critical categories of information. The first one is the most fundamental, a deep dive into your hormones and your ovarian reserve.
Okay.
We look at key markers. AMH is the big one for quantity. It tells us how large that available pool of eggs is.
And then you have the hormones you check at the start of the cycle, day 2 or day 3.
Yes, FSH, LH, and estradiol, or E2. That's our functional snapshot.
What does that tell you?
Well, FSH tells us how hard your brain is working to signal your ovaries. So a high FSH suggests the ovaries are, not listening very well.
You're resistant.
Exactly. And LH and E2 give us a picture of the current hormonal environment just to make sure we're starting at a good neutral point. Then we combine all that with the AFC.
The antral follicle count.
Right, which is just a simple ultrasound count of the tiny resting follicles we can see.
And that data, the hormones and the AFC, that's what really allows you to classify the patient's expected response.
It's the foundation. It tells us right away if you're likely to be a low responder, a normal responder, or a high responder. High responders often being patients with PCOS.
Okay, so number 2 is age. How does age specifically change the protocol beyond just, the biological clock?
Age is critical because it shifts the entire goalpost from quantity to quality.
Right.
We tend to use age groups like under 35, 35 to 38, and then 39 plus to estimate the probability of chromosomal errors in the eggs.
So for an older patient,
For an older patient, the focus immediately shifts to maximizing the quality of every single egg, even if it means the total number is smaller.
makes sense. The third piece of this data puzzle is the full medical history, and this goes beyond just fertility, right?
Oh, absolutely. We have to account for conditions that can interact with the stimulation drugs. We're talking about things like endometriosis, previous ovarian surgeries, autoimmune diseases, or even metabolic issues.
Like thyroid or insulin problems.
Exactly. Thyroid, insulin resistance, weight issues. All of this data tells us if we need to do some kind of pre-treatment or adjust the medication types to be safer and more effective.
The fourth point sounds like it might be the most valuable of all, if you have it, a previous cycle's response.
It's the gold standard.
Ah.
I mean, if you've been through a cycle before, that data is priceless. We need to know the exact medication dose used versus how many follicles actually grew.
And not just how many eggs.
But how many were mature, the MII count is critical. And of course, any history of OHSS. This tells the clinic exactly what worked and, more importantly, what not to do again.
And the fifth input, which I found interesting, is the male factor. How does the partner's sperm quality actually change the woman's protocol?
Right, it seems a bit disconnected, but if there's a severe male factor, I mean, very poor sperm count or motility, the strategy for her might shift slightly.
In what way?
In those cases, the doctor might aim for a moderately higher number of eggs. It's not about improving her egg quality. It's about increasing the total pool size to give the lab more to work with. It allows for greater selection, especially with techniques like ICSI, to find that one best sperm.
That's a really clear data picture. So now let's get into how this actually works. How does this customization change the strategy in specific scenarios?
Great. Let's start with a common one. Scenario A, a patient with PCOS and a high ovarian reserve.
Right, so this is the patient who is very prone to over-responding.
Exactly. The goal is to get a good number of eggs, but to do it without triggering OHSS, which can be dangerous. The entire strategy is about calibrated restraint.
You're hitting the brakes, essentially.
We're tapping the brakes from the start. The tactics usually involve starting with much lower doses of gonadotropins, and we almost always favor an antagonist protocol here
Why is that?
because it gives us more immediate control. It's just easier to slam on the brakes if we see those estrogen levels, the E2, spiking too quickly.
And the trigger shot is probably the biggest change here, isn't it?
It is the most critical difference. We use what's called an agonist trigger instead of the traditional HCG trigger.
What's the thinking there?
It's all about the mechanism. An HCG trigger stays in your system for days, causing this relentless stimulation that leads to OHSS. But an agonist trigger, it uses a hormone that mimics the brain's natural signal. It causes a sharp, very short-lived surge that clears the system fast, which dramatically minimizes that OHSS risk.
That's a brilliant distinction. And because of those high hormone levels during stimulation, this strategy often ends in a freeze-all cycle, doesn't it?
Almost always. That high estradiol environment is actually hostile to a fresh embryo trying to implant. So the smart move is to freeze all the viable embryos and transfer one in a later, much calmer cycle when the uterine lining is perfect.
Okay, let's switch gears completely. Scenario B, the patient with low ovarian reserve, low AMH, low AFC. Here, the goal is all about quality.
The goal shifts entirely. Customization here is about finding the perfect dose that recruits the best eggs without just wasting medication. We want to avoid what some sources call ineffective megadoses.
Right. Just throwing more drugs at it doesn't help.
It doesn't. Past a certain point, more medication doesn't recruit more good follicles. It just adds cost and side effects.
And this is where we see some really innovative protocols like mild stimulation or DuoStim.
Yes. Mild stimulation uses lower doses, sometimes for a bit longer, focusing purely on quality. But the really fascinating one is dual stimulation, or DuoStim.
The DuoStim is based on the idea that we don't just have one shot per month to get eggs.
That's it, exactly. The old thinking was that follicles only grow in the first half of the cycle. DuoStim leverages the new understanding that different waves of follicles develop all the time. So you stimulate in the first half, do an egg retrieval, and then
You stimulate again in the same cycle.
you stimulate again in the second half, the luteal phase, for another retrieval. You essentially get 2 chances in 1 month, which for a low responder racing the clock is invaluable.
Wow. Okay, let's talk scenario C. Patients with endometriosis or who've had ovarian surgeries.
Here, the goal is an extremely delicate balance. We have to stimulate enough to get eggs, but we absolutely cannot worsen the inflammation from the endometriosis or damage that already compromised ovarian tissue.
I can imagine a really aggressive high-dose protocol would be a disaster here.
It could be. It can flare up the inflammation or even harm the scarred ovarian tissue. So the tactics involve very specific protocols, sometimes pre-treatment with a medication to calm things down before the IVF cycle even starts. And the overall strategy is often to plan for multiple, shorter, gentler cycles rather than one big, aggressive one.
It's about preservation.
Total preservation of what's left.
Okay, our last scenario, scenario D. This one is for the patient who makes good embryos, but they just don't implant. Repeated transfer failures.
Right. So here, the personalization focus shifts completely away from the eggs and ovaries. It becomes all about the timing and the uterine environment.
What are the tactics?
First, we almost always move from a fresh transfer to a frozen embryo transfer, or FET, protocol. This lets the uterus recover. And then, crucially, we customize the progesterone support.
How can you customize progesterone?
Progesterone is what opens the window of implantation. We can customize the dose, the form switching from vaginal support to injections or combining them. And we can even adjust the timing of when the progesterone is started by just a few hours to sync it perfectly with the embryo's stage.
And what about advanced tests like the ERA test?
Those are powerful tools, but they really shouldn't be routine. An ERA, which maps the endometrium's receptivity, is generally reserved for cases where multiple high-quality embryos have failed to implant. And we really suspect that timing is the stubborn core issue.
So it sounds like the plan is never set in stone. Even after stimulation begins, doctors are constantly fine-tuning everything.
That dynamic fine-tuning is what makes it personalized. We're monitoring follicle growth every day or two measured in millimeters, along with daily blood tests for estradiol, progesterone, and LH.
So if a patient's follicles are growing too fast,
We take immediate action. If the follicles or the estradiol levels are climbing too quickly, we might reduce the gonadotropin dose that very night or plan to trigger maturation a day earlier than we'd planned.
and if it's too slow,
The opposite. We might nudge the dose up slightly or extend the stimulation by a day or two to give those follicles the time they need to mature properly.
and even after the retrieval, that support phase is personalized.
Yes, the luteal phase support. It's customized based on your history and your hormone levels. Someone with a history of recurrent loss might need a combination of injected and vaginal progesterone or just need to be on it for a longer period of time.
We touched on the fresh versus freeze-all decision, but it's worth stressing that this is a key personalized choice made during the cycle.
It's purely data-driven at that point. The doctor is looking at your final estradiol level, your OHSS risk, the quality of your uterine lining that specific cycle, and whether genetic testing of the embryos is planned.
Then if the body's too stressed.
If the body is overly stimulated or the E2 is sky high, freezing all the embryos for a future, healthier transfer is always the smarter and safer choice for success.
This all paints a very hopeful picture, but we need to ground it in reality. What can personalization really achieve, and what are its limits?
That reality check is so important for mental resilience. Look, personalization can dramatically reduce your risk of complications. It can increase the number of quality eggs you get relative to your personal reserve, and it really improves the sync between the embryo and the uterus. It shortens the time to find a strategy that works for you.
But it's not a silver bullet.
It's not.
Mhm.
Personalization cannot change the inherent chromosomal quality of eggs that's tied to age. It cannot guarantee a pregnancy, and it can't eliminate that element of, biological randomness, that bit of luck that's always involved in reproduction.
So the message is,
Personalized IVF is about the smarter use of what your body already has. It's not magic.
I think that framing is really empowering. It focuses the energy where it actually counts.
So what is the listener's role in this? How can you be an active partner in your own personalized plan?
You have to be an active partner. The first step is to ask smart, specific questions. Don't just accept the protocol. Interrogate it.
Like what?
Ask, why this specific trigger for my AMH level? Or, what did we learn from my last cycle, and how is this starting dose different? What's the goal of this specific medication?
And keeping your own notes is probably a good idea too.
It's vital. Document how you feel, any side effects, and even just how this cycle feels compared to a previous one. That subjective data is actually incredibly valuable to the doctors when they're making those mid-cycle adjustments.
And what should you ask for when the cycle is over? You should demand a clear, detailed summary of the data. Get the numbers. follicles grown, eggs retrieved, the maturity rate, the embryo grades, and get a clear assessment from the clinic on what they learned about your specific response.
So if you ever have to switch clinics.
That report is the foundation. It lets the new team start with personalization from day one instead of starting from scratch.
So the big takeaway here seems to be a real philosophical shift. We're moving away from treating the average patient and focusing intensely on the individual, their specific hormones, their history, their goals.
It's all about more data analysis and less autopilot. It's a commitment to refining the strategy with every single cycle. And that leads to better outcomes, not just in pregnancy rates, but in fewer complications, fewer lost cycles, and a journey where you feel much more informed and respected.
We really hope this deep dive has armed you with the knowledge you need to understand your own strategy and to ask the right questions.
We must emphasize, clearly and directly, that this entire discussion has been purely educational. It should not be considered medical advice.
If you want more information on the complete IVF process, you can find it at the portal IVFforme.com.
Thank you for joining us for this deep dive.